on who should do REBOA and training issues in REBOA. Can the panel members please come up and take their seats? And while we wait for Dr. Hohn to get ready to give her talk, can the panel members just please briefly introduce yourself? Panel members, please introduce yourselves. Just a name and where you're from.
Edmund Søvik, Trondheim, Norway. Interventional radiologist.
Jan Jansen, Trauma and Intensive Care.
Jim Manning, University of North Carolina, Emergency Medicine.
Pep Talving, Surgeon, Estonia.
Bijan Dervish, Anesthesiologist and Intensive Care Medicine, Karolinska Hospital, Stockholm.
Göran Wallin, Chairman, Göran Wallin, Department of Surgery, Örebro, Chairman.
Great, thank you very much. Ready for our first presentation, Dr. Hohn, US Best Courses.
Good morning again, and thank you. Before I get started, I'm going to be talking about the best course here, and I just can't talk about the best course, of course, without mentioning Dr. Brenner. So, well, it's an honor for me to be here and speaking about the course. Really, this is all a result of Dr. Brenner's great thinking and dedicated effort to training trauma surgeons. So, the best course, Basic Endovascular Skills for Trauma. And what this started as was basically a folding table, a Mentis simulator, and 13 of our own faculty. After the first REBOA was put in at shock trauma, Dr. Brenner started on a mission to see if we could train acute care surgeons to do this safely. And at the time, we had the 12 French sheath. We just one by one brought them in through a mini course of didactics and 6 sessions on the 6 runs of placing the REBOA on the simulator. And they performed them 6 times, as I said. And what we found is that all were able to demonstrate competency in terms of sequence of steps, accurate placement of devices, and then what we consider to be safe use of endovascular tools. And we found that even in this short session, we were able to show significant improvement in both knowledge and procedural time. And our surgeons were very enthusiastic about this. And shortly thereafter, there was a significant increase in the number of REBOAs done at shock trauma. And much to our delight, they were done safely and appropriately. And from that, we were invited to a national meeting to do a workshop, and the interest was overwhelming. And from there, the natural progression was a monthly course in Baltimore that we still offer. This includes training on the ER REBOA catheter. We still do teach the CODA as well, and some basics of pelvic angiography. The focus for us has always been on sort of a practical clinical knowledge, and we like all of our instructors to have some kind of real-life experience placing REBOA, and that's one of the key components. There are 3 parts to the best course. There's a didactic session, a simulator session, and then a perfused cadaver model. Early on in the course, the didactic session was devoted mostly to technique. We didn't have a lot of literature to be speaking about, and that has definitely changed. Now there is some discussion of clinical and animal research, but more so, again, the indications, management, and then how to manage and to prevent your complications. It's amazing to me how often we have to revise the slides for the best course, and mostly that's due to a number of people in this room, but the focus, again, is mostly on technique. Again, the best course has been an evolution. We initially started with an endovascular simulator, and we still do use the simulator, but we have moved on a bit. The simulator itself, I think, is very good for repetition of steps, some basic wire skills, and to get an idea of what it's like if you do have fluoroscopy available to you. But the simple fact is most of the time REBOAs are placed without fluoroscopy, at least in our institution. And so we found the very reasonably priced silicone models are actually very good for this. They have an accurate correlation of measurements, real wire exchanges, and a much more lifelike inflation feel on the balloon. And then as we have advanced, we've also trained on different kinds of simulators, perfused models, some with a groin simulation as well, and the technology for REBOA training is advancing quickly. I think what's unique to our best course is the pressurized cadaver model. Cadavers are refrigerated, they're not embalmed. We do try to avoid those patients with a history of arterial reconstruction or severe peripheral vascular disease. We place them on a fluoroscopy table. We then expose the carotids, the jugulars, the brachial artery vein, and the femoral artery and vein as well, and ligate these. Then using a pump. We infuse colored saline through the carotid artery and drain it out the internal jugular vein as necessary. And with this, we found you can actually perfuse to a systolic blood pressure of approximately 50 to 70. The other interesting thing about it is you can see there on the monitor, we actually do get a pressure change on the monitor with inflation of the reboa, which we like to teach people to be watching the blood pressure when they inflate. We don't get as much as we do in real life, but you get a 20 to 30 millimeter mercury jump in the systolic blood pressure with that. We think that the cadaver model offers us a lot of advantages. Again, you can do the entire procedure with a real-life feel from start to finish. We train both ultrasound and open femoral access and exposure. I think that's maybe one of the limitations of the animal model. And arterial closure we can teach as well on the cadavers. We also can do interpretation of both ultrasound and X-ray images. Just like in real life, the balloons don't necessarily go specifically where you want them, particularly when we're training people. And we teach people how to interpret the look of the balloon, where it's at in terms of some of the bony landmarks, and it really gives them a good example of what it's going to be like when they do it in patients. Again, it also has a varying tactile feedback in the wire that you can get in the cadavers that you may or may not get with the simulators. And you can feel when the wire is bending and when it's folding. And so it's a really nice way to teach people about what to expect for the feel of the different pieces of equipment. And what is the best course today? And now we've trained over 300 acute care surgeons, 300 physicians, mostly acute care surgeons from several different countries. And currently it's open to all surgeons and then ER physicians that are in the military. It very recently became a course at the American College of Surgeons and is expanding throughout the country. We have a course here in Houston now led by Dr. Laura Moore and at UC Davis by Dr. Joe DeBose. And we anticipate that we're going to continue to expand this and roll this out across the country. So the best course, we're continuing to integrate new clinical and animal research. Hopefully we'll implement new technology in other endovascular arenas as it becomes available. And there's going to be the addition in time, I believe, of more ER physicians that are going to be taking the course. But there are questions that still remain. How do we maintain a skill set for a procedure that's done so rarely at most institutions, first and foremost, I think? And how do we certify or credential people in the procedure, and who should have that capability? I think those are all questions we're still trying to answer. So again, thanks to Dr. Brenner. She's really the one who's put the work in on this, and I just appreciate being a part of it. Thank you.
Great, thank you very much. Are there any questions and comments from the audience? From the panel members?
I've got a question. Great talk. Great course. The cadaver model, I think, is the best model. My question is, how do you declot the cadaver when you put the cannulas in the femoral vessels? How do you declot them? Because we worked quite extensively at the LA County USC cadaver lab by declotting, and we pumped from both sides the pressurized model, arterial, venous, 2 pumps, and we got them mean arterial pressure up to 70-80. So it was a really great model. Mm-hmm. Now, what we did know that the capillary bed is clotted off. You can't pump in from the arterial side and hope that it fills the venous side. It does not. How do you solve the declotting and of the cadaver?
So I know that the cadaver is flushed fairly extensively. I can't comment on those details except that it's done from the carotid artery. But you're absolutely right. The venous system is not involved. So when you cannulate the venous system, accidentally sometimes, you do still have a clotting problem there. But the flushing seems to take care of any arterial clot, and that doesn't seem to be an issue.
And it's a one-day. Sorry.
Victor,
please.
Melanie, thank you for this presentation. In St. Petersburg, we tried to develop such a model, pressurized cadavers, and so we failed a couple of times because of the body is becoming swollen very fast. So how do you manage to? So how long time can you do all this endovascular stuff? So Rebo or any others? I mean, so when the body permits?
So absolutely, the swelling is the limiting factor for how long you can perfuse the cadavers. What we do is we intermittently perfuse them. So there's a switch that the instructor has that sort of turns them on and off as necessary. So when you're floating wires and inflating the balloon, you then perfuse it, but then you switch it off when you're working with ultrasound and teaching. There's a great deal of variation in how much the bodies swell as well. And we do place a catheter in the jugular for drainage, but we don't really, to be frank, we don't really use that catheter. It's just a matter of limiting the amount you perfuse.
Okay. And did you try to perform angiogram, aortogram in the cadaver using your perfused cadaver?
We did that when we were sort of exploring the model. Because we don't really teach angiography on the cadaver, it's not something we do frequently, but you can get some basic images with it.
Thank you.
Right, that's just about time. Laurie, just reserve your question for discussion time later. Thank you very much. Next up, Tal Hörer, the Swedish training experience.
Okay, I thought this film shows everything I want to say, so I will not use any slides. Shortly, I think in Örebro, with great help from, for example, Göran Wallin and other people, we could, and with the leadership of Thomas Larsson, could these years workshops. How many workshops totally? 54 workshops. These are vascular, endovascular, technical workshops, different forms of them. I'm sorry. With cooperation with other people, for example, with the Direct Society, other people coming here, people from South Africa and other nations, we could build also trauma workshops and endovascular hybrid workshops, and this is the EVTM. The most difficult with this workshop is the fact that we're taking in people that have very different backgrounds. We're taking people with 30 years experience of open surgery. I will not teach them open surgery. And people that did, for example, 50 Riboa, like Tomohiko, etc., etc. So this is not the point, and Riboa is not the point. The point is, I'm sorry, the point is of this workshop is endovascular and hybrid trauma and bleeding control. So we think by combining effort with other people and trying to get a good platform, using other people's knowledge, we all learned, and personally we all, I think, learned by seeing people with us and contributing in different ways. We've seen cases, and I know there have been clinically cases done after the EVTM workshop. For example, one PPH bleeding in Israel was done by a very experienced guy that's been to the workshop. He can do Riboa much faster than what I can do. He applied it in the way he thought it's appropriate in his setting to the correct patient. I hope we can continue with this, develop it. I think this format, it's quite good and can be always better. Sorry. the last workshop now, I told the people coming, I'm sorry if it seems a bit disorganized. It looks like we're changing all the time. Oh, guys, we go there. Oh, come here. We do like this. But that's the whole point, because we get so many ideas while doing it. So it's not it's not a course. It's a workshop, and there is a huge difference. Thank you so much, and thank you all for coming, and the people that came to the workshop. Thank you.
Tal, one question. When is the next course?
We don't know.
I'm sure the course will be fully booked on the first day you give us the dates. Thank you.
Thank you.
Any questions, comments to Tal regarding the EVTM workshop? There is one. Can we get Mike up there? Thank you.
Hello, Christopher Jönling from the Karolinska. I was just wondering, how is your relationship with the ECMO guys? And have you thought about cooperating with them on this course? And perhaps the question is also in a bit to Jim Manning regarding arc perfusion, and have you thought of expanding it into those realms?
I will answer shortly. Yes, we love ECMO, and we do ECMO in our institute, and we think it's a great tool for the right patient, right place, right time. And the answer is yes, definitely. Reboa is bridged to ECMO and other situations, not only trauma. The answer is yes, it's expanding. I don't know if Jim want to comment.
Well, I guess certainly if what I'm working on with this like SAP technique, it gets to where it's in clinical practice, I would hope that it would be part of what you do. My question actually to you is, it sounds like right now the courses that you're teaching are primarily focused toward vascular surgeons, trauma surgeons, and teach a lot of techniques beyond Reboa. But if we do see this steady progression of the use of Reboa and moving more toward, say, emergency department and pre-hospital care setting, do you have some thoughts on how you will sort of refine or create another course that sort of focuses on those individuals who will be out, say, performing these endovascular techniques more far forward?
I will tell you the truth, I don't have any idea. I can think about it. But we had people from paramedic level, military guys, professors in surgery, intensivists, everybody that is interested in this have it. That's the idea, that if you want to have tools for bleeders, it doesn't matter what's your title. You can be a cardiologist that can do very fast access and help a gynecologist in trouble. So we have to refine and do it better and more directed. We're trying to do it individually tailored to the person standing there. That's the issue. We can be better.
Any more comments or questions? Tal, I just have a question for you. When I came to your workshop in, I think it was September last year, one thing that, because I was new to the actual use of Reboa, one thing that confused me quite a bit was that there was a whole bunch of different types of catheters, different sizes and different all these things. And it was really confusing me. Is there any way of getting around that, having a more systematic way of perhaps teaching one catheter first and then showing all the others, or I don't know. What are your thoughts on that?
I'm sure there are ways to do it. As you understand, we're learning all the time, and as you know, we're learning all the times. We try to simplify it, but I guess we ourselves are confusing my endovascular role in the hybrid suite when speaking with you in the trauma setting. So we probably have to refine it ourselves and make it easier in this jungle of catheters and all the products.
Good. Thank you very much. For our next talk, the Japanese Reboa Direct course, Dr. Jun Matsumoto is standing in for Dr. Funabiki.
Good morning. On behalf of our society, Direct Society, I'd like to thank you very much for letting us being a part of this great program. I thank you very much. Today, I'd like to talk about our society, and this is a result from the questionnaire survey done by Japanese Society of Emergency Radiology. Japanese, and the question, the red part is radiologists, the blue part is clinicians. And the question was, who read emergency CT in daytime? And less than 50% done by radiologists. So it means radiology coverage in Japan is so limited in daytime. So when we ask about the night shift, the answer is like this: 80% done by clinicians. So this is so unacceptable for me because I'm a radiologist. And when we ask about IR, this is a question: how many minutes from the call to the angio? And at about 70% of institute hospitals, they cannot start emergency angio within 30 minutes. So this is also unacceptable for me. So in this situation, we need to have something suitable concept. That's why we've suggested PREST concept prompt, rapid red endovascular strategies in trauma occasions. And we needed to encourage radiologists to get involved more clinically. And we say, why don't we make radiology great again with this concept? But they responded like, we have been already great, and we have been busy to do something else from 9 to 5. And in that situation, okay, we need to do something else with doctors who are working beside patients. So that's why we started Direct Society. And DIRECT is abbreviation for Diagnostic and Interventional Radiology in Emergency, Critical Care, and Trauma. And it is established in 2011, and so far we did already more than 60 courses, and we got more than 1,000 participants. Like other courses in the world, most of the participants are clinicians, very limited number of radiologists. And in our courses, the courses are consisting of IR educational course, diagnostic imaging course, and case-based discussions. And in the diagnostic course, we teach how to read pan scan images in a quicker way. And these are the pictures from the lecture courses. And in the IR courses, we used simulator and animals. And in the course with simulators, we teach rebore and catheterization and how to use embolic agents also. And so far, we did 14 courses with simulator. And in the animal courses, we used rebore. And we teach rebore, we teach how to catheterize and how to select the catheter. And with injury scenario, we teach how to embolize or how to use the embolic agent. So far, we did 10 with animals. And in the simulator workshop, these are the pictures from those. And we use 3D vessel model. And we also used the virtual fluoroscopic simulator from Mentis, and it is very good, and you can experience there. And we also teach how to select and how to use embolic agents. And with live animal workshop, we scan the pig. We scan the pig, and to get virtual fluoroscopic image from CT data, it enables you to select the branch easily. So that's why we scanned the pig first, and we made the virtual fluoroscopic image. And we try to share the concept of COA system. It's a part of Presto, and there's one guy sit behind the team and conduct the whole team during the workshop. And we use, as I told you, we use injury scenario, and we try to experience them to, we try to let them experience the hybrid trauma team using Reboa catheter, embolization technique, and surgical technique. We try to do those at the same time under the concept of Presto or using the pig. And these are the pictures from those courses. And when we start our society with the clinicians, the Japanese society, there's many guys from Japanese Society of Interventional Radiology, they got mad against us. So we needed to talk. Actually, we needed to ask them to help us. We don't need to exist if they can do that. So please help us, or please do something by yourself. Then they start to understand slowly. And now we start to organize ad hoc committee for trauma IR training, which is suitable for clinicians. But the process is very slow so far, but I think we can see some progress in the future, near future. So that's the current status of Japan. And this is another result from the questionnaire survey at the meeting, IR meeting in Japan. And the question was, are you going to train clinicians as well? And the answer is so far 70% said yes. So we will see. Thank you very much for your attention.
Thanks, June. That was a fantastic talk. Comments and questions? Audience, panel? June, can I just confirm, who is actually currently attending the talks, the courses?
I'm sorry?
Is it radiologists that are currently attending the courses, or is it currently open for clinicians as well?
Yeah.
For everybody?
Yes, for actually we are so open for everybody. Sometimes the radiology tech take the course. So we are so open for everybody, but very limited number of radiologists attend the course. That's the really.
Are you finding that, let's say, surgeons who have attended the course, are they actually doing interventional procedures?
Yes.
By themselves?
Yes. And right after the course, some clinicians try to do the procedures in human, but they did sometimes too aggressively, and they made some terrible mistake. So we experienced that. So we encourage them to take longer educational rotation in radiology.
Right. Okay. Question up there.
Hello. My name is Pantelis Vasiliou, surgeon from Greece. Until this point, I remained silent because I want to see what is this thing about. I didn't have much clue. Now, with these last two speakers, I have something to say, so this is it. As Dr. Matsumoto said, there is no reason for the radiologist to exist if not surgeon exists. And surgeons don't have a reason to exist if no trauma victim exists. So the communication, the collaboration between all against our common enemy, if I may call it like this, the trauma victim, is what offers best results. So above Reboa and above the endovascular technique and above the surgeons, this introduces a new, if I may say new, approach altogether against the common enemy. And in addition, this panel formation, which is brief talks, and actually in 7 minutes, if someone has something to say, can say it very well, offers much more than what we have used to major conference, long talks, and with no end. And a final comment. The name creates limitations and creates opportunities. You may think, although it probably is too late, rename Reboa in Rebo V, because Someone might think, why just limit your attempts to aorta? We may use any named vessel and even any named vein. And EVTM could be EVBM, because you treat bleeding, you stop bleeding. You don't treat trauma in general. So that's it. Thank you.
Thank you very much, June. Our next talk is from Dr. Leun, Lessons from Copenhagen.
Thank you, and thank you for the kind invitation. And I can't stop thinking that Tal Hurriher, he's like a Nobel Prize winner, you know? You know who I'm thinking about? The young Bob Dylan? Is it only me? So it's actually fantastic, the work he has done, and I'm proud to be part of this today. This is this morning, and we're going to talk about Reboa training methods on simulators and more. I have a conflict of interest. It is a Mentis company. So before you do training at all, you have to know what is the meaning of having a training, or who you're going to train, and what are the challenges with this, and your focus. So first, I just go back what you have talked about earlier, both today and yesterday. It's the unstable patient. You have a certain logistics with this, and the thing is that the critical criterion is the time to hemorrhage arrest. And I'm, as a 30 years of endovascular specialist, working in anesthesiology from the beginning, actually. You have the patient, and you have the time to hemostasis, and you feel a bit worried. As an interventional radiologist, I advocate very much a fast CT, not a fast ultrasound, in order to get a clue on what we're going to do. In order to train, we have our endovascular simulation center 100 meters from the hospital, and we work very closely with them. You have this, where should you work? Should you work in the classroom? Should you work at the sim center? Should you work directly in situ, or very, very close together? On the x-axis, you see you can have an exclusive teamwork focus. You can have a blended teamwork. It depends on what you want to do and who you're going to train. With lots of literature out there that endovascular simulation training works, so you actually can get your pupils over the bridge. What you can do in any simulator, the Symbionics or the Mentis machine, is that you can actually put the DICOM data in there, and you can use haptics to train in real life, the same way as you do in the real setting. You heard earlier about the speak about the Reboa balloon technique, how you could train this in a setting, and how they decided what their learning goals were. And you can see that you were quicker with this. I've trained roughly 5 specialists to a PhD only in simulation, solidly there, for the simulation training program. In Copenhagen, we have made it mandatory. If you want to be a vascular surgeon, you have to go for an endovascular training course, not once, but twice, and you have to integrate it into working with a specialist for iliac endovascular training. And you are assessed on it. And you can discuss what is assessment, how can you do that? You can do that by doing PhD work on it, to work together with psychologists, behaviorists, etc., to understand what is a good behavior, what is the way to work with, how could you assess? Because you're going to assess people, and they're going to be furious if you assess people if they think they're still good. So you have to have reliable scientific knowledge so that you can relate to this. When you work with simulation and training, you also have to decide on, is it the technical experience you're going to train, or is it the cognitive and diagnostic function, or is it failed communication training you're going to do better? So what do you really want to achieve if you have a course or a workshop? Is it individual skills? Is it group skills? Is it team training? And you also have to measure it afterwards. Not only was it good coffee, or etc., etc. Was it good people coming there? Was it good network for me? You really have to do this in a more scientific way. Recently, we are in the Mentis company with the simulation. We also collaborate with the Leerdal simulator. So in that setting, what I think is important if you do it as a teamwork, you really have to get all involved, cardiologists, anesthesiologists, anesthesia nurses, the endovascular specialists, the scrub nurses, etc. So you build the scenarios in this way. So in the SimMan, there are a lot of things you can do with the SimMan. In the endovascular simulator, there are a lot of things you can do with that. If you combine it, it actually 1 + 1 gives 4 or even more. So you can do this already from an outdoor setting, from a paramedics, all into the operating theater and to the ward afterwards. I know that in Saudi Arabia they have tried to build a total simulation hospital at the King Fahd Medical Center in Riyadh. So we have been consultant there for a certain time, a couple of years ago. So in advanced simulation training, that could be to compensate for the lack of in real-life training, or in combination with it, or to train collaboration and team approach. And that's what I think is so fantastic with this kind of meeting. That's essentially total new context, a new group of people. And I'm really amazed to listen to all the experience you have in this field. But I would like to emphasize the last minutes of my talk on the Pandora's box. When you do this with put an occlusion balloon in, you can actually continue doing transarterial embolization. And then you have to learn how to do that kind of procedures, or a combination of them both. I heard earlier that you can open up and you can pack for the pelvic fractures, etc. But you could put in an occlusion balloon, and then you could embolize in the same setting as well, if for the right patient, at the right center, etc. So in conclusion, you can use simulators to reduce the risk to patients and staff. That goes also for radiation training, which I don't mention so much here, but radiation is dangerous. So you really have to learn how to behave when you use X-rays. And simulators do not compete with clinical equipment needs either. And they allow assessment of competence and proficiency. They allow optimization and training for new techniques. Vendors of interventional endovascular equipment should use simulation more and more for optimization prior to the use. And simulation will form part of the strategy for delivery of the new training requirements. And in that way, we can live happily ever after. Yeah. Thanks.
Can I just get it clear in my own mind? Are you teaching a structured course in Denmark at the moment on endovascular techniques?
We do, and interesting enough, I'm working both with cardiologists previously and with interventional radiologists and with vascular surgeons and cardiovascular surgeons, but I'm an interventional radiologist in my clinical setting. Those who have been most interested are the vascular surgeons, for obvious reasons. And this is a structured course that has been together with Professor Torben Schröder, who is a vascular surgeon. We're very pushing, emphasizing, managed to get this as a mandatory course for whole Denmark. It combines of 2 days plus 2 days. You have to attend 10 ILIAC courses by an experienced senior consultant, and then you try to do that. You write reflection reports, etc., and then you are assessed. You are assessed with a test that is based on earlier work we have done for PhDs.
You're saying 2 days plus 2 days?
2 days plus 2 days, yes. It's still, but in that period, you start doing 10 cases, looking and seeing how a senior does, and you have to make a report on that. Otherwise, you're not allowed to come to the course.
Okay.
That's the way it is. In order to get your license as a vascular surgeon, you need to attend and get your approval of your course.
Okay. Thank you.
They have the same for hysterectomy, by the way, as well. It's mandatory to be an OB-GYN doctor in Denmark. You have to do roughly the same test.
Okay.
In that setting.
Thank you. Wonderful presentation. I'm interested in when you're doing these sort of simulations and stuff, there are two things I've heard discussed in this, is that if you look at human patient simulators, that they have very good anatomic fidelity, but the tissue handling fidelity is not there. Whereas if you use animal models, you certainly typically don't have the anatomic fidelity, but the tissue handling fidelity is there. If you use a perfused cadaver model, you come the closest to having both in the same model. But for this type of thing where endovascular techniques, and a lot of this is feel and tissue fidelity, what's your thought on the relative importance of, say, human simulators versus animal models in this sort of educational process?
Thank you for that. I had a PhD who is a Native American who did this as a PhD. He compared animals, pigs, training courses with endovascular training. And what we noticed was if you train on a simulator, you of course get better on the simulator. If you train on in an animal setting, you get better on that. What they did was we actually we did a randomized control study. So you did animal studies first and then simulator, or the other way around. And